Okay. I would like to introduce my colleague Eileen Reichert, who's our training center coordinator, and she'll get the program started. Thanks.
Thanks, Jennifer. We are so blessed to have such talented people here, and I just want to tell you who our players will be. Reed Ferris is an assistant professor at the University of Washington Department of Pediatrics and attending at Seattle Children's in the pediatric ICU and at Harborview. Sylvia Hartman is an assistant professor as well, University of Washington, and a pediatric attending physician in the ICU here at Seattle Children's and at Harborview. Joan Roberts is assistant professor of pediatrics at UW School of Medicine and is an attending pediatric critical care medicine physician and is our chair for code committee and has been incorporating PALS algorithms into our code committee and procedures and policies. So that's great. Jennifer Reed is Associate Professor, Department of Pediatrics Division of Emergency Medicine, University of Washington, and attending physician in the Pediatric Emergency Medicine Department, and is co-director of the Pediatric Emergency Medicine Simulation. We are using SimBaby today, and that's part of our simulation process is to create more realism so that we can be ready for when the real thing happens. Other players and actors in our simulation today is Elaine Beardsley, clinical nurse specialist in the emergency department, Heather Johnson, pediatric critical care nurse, Jennifer Peterson, nurse educator in the cardiac ICU, Hyan Tang, outreach education pairs educator, and Hector Valdivia, pediatric ICU nurse educator. Alberto Armas is our simulation technician, and we have Taylor Loudon from the emergency department as emergency department fellow. So we have lots of talent here today who are going to put together some interesting scenarios for you. We'll start out with Reed Ferris, who is going to give us some overview of the pediatric advanced life support guidelines 2015 changes. Thanks.
Thank you, Eileen. We do have some objectives for the hour, and they primarily center around our new 2015 AHA guidelines for PALS, both BLS as well as ALS. We're going to talk about applications of the new guidelines in the care of children and utilize a team approach to the communication skills while we implement these to improve our patients' outcomes ideally. We don't have any conflicts of interest to disclose or any off-label product use, and we don't have any commercial support or sponsorship today. So here's an outline of our day. We're going to start off with an overview of some of the changes specifically to BLS as well as ALS in the setting of cardiac arrest. We're going to talk about BLS and high quality CPR. We're going to talk about the guideline updates on atropine for intubation, as well as the recommendation for CPR feedback devices if available. Then we'll actually run a ventricular fibrillation cardiac arrest scenario. We'll go through that and demonstrate the use of that PALS algorithm and the subtle changes to that. And then with that, we'll then I'll come back to the podium and we'll talk about the specific changes to the algorithm around the use of antiarrhythmic medications and the recommendations thereof. And then I'll briefly mention the targeted temperature management recommendations that have also changed a little bit since our last update. That will finish our cardiac arrest scenario, and then we'll move on to a neurologic deterioration scenario. Joan Roberts will come up, talk a little bit about the rapid response process and code response process in an individual with potentially increased intracranial pressure. We'll then run a scenario highlighting that process. And then we'll finally move to septic shock. There are some very subtle changes to the septic shock recommendations. And so we'll talk about those changes briefly and then run a septic shock scenario as well with Jen Reed and her team. So diving right in, our pediatric BLS updates for 2015 are not huge changes, but some subtle realignments to the recommendations. there are 5 components that have been updated to try to achieve high quality CPR for the BLS component of the guidelines. One is to align the compression recommendations to be the same as the adult algorithm, to try to do away with different guidelines for adult BLS versus pediatric BLS, and to unify the guideline recommendation to 100 to 120 compressions per minute across the age ranges. As I mentioned briefly, in BLS and with CPR, the recommendation is to utilize feedback devices if they're available, and we'll highlight one of those here in a second. The depth of compression for BLS has been updated a little bit with more specific recommendations for the depth. Still trying to adhere to 1/3 of the AP diameter of the chest, but having a more specific guideline to, if you're an infant, that equals about 1.5 inches. If you're a child, it's about 2 inches, and adults, adolescents and adults, 2 to 2.5 inches for your compressions. Again, still highlighting complete recoil after those compressions. Hands-only CPR is taught in the community. For healthcare providers, BLS, for the pediatric patients, the understanding is that most pediatric cases of cardiac arrest are secondary to a respiratory insult. And so if individuals are available that are able and willing to provide rescue breaths, then conventional CPR with compressions as well as respiration should be provided for pediatric cardiac arrest, unless rescuers are either unable, unwilling, or have not been trained to provide that level of resuscitation. But for those of us in a healthcare setting, the recommendation is when we're taking care of kids, doing conventional compression and respiration CPR. And finally, for the end of the BLS, moving into ALS guidelines, the routine use of atropine has been scaled back. So atropine, if indicated, but pre-intubation is discouraged to use it routinely, only in situations that may be patient-specific. The CPR feedback devices that I briefly mentioned are demonstrated here that are specific to the device we use here at Seattle Children's. Our monitor defibrillator that we have in place throughout the institution has this feedback inherent in the device. The specifics on which patients and which pads can utilize the feedback is a little more than I'm going to get into today, but this is just a demonstration of what the screen looks like. I can use a mouse here. So when using the pads that provide the feedback, you get feedback on the depth of the compression, the rate of the compression, and whether you're getting full recoil between compressions. And then there's an overall quality indicator here that is a combination of these 3 aspects. So if your rate is good, your depth is good, and you're getting full recoil in between compressions, then your what they call a perfusion performance indicator fills up, as you can see down here on the bottom right. If you're not doing a good job, if for any reason your release or your rate or your depth is inadequate, the device gives you directed feedback that is audible. It starts to yell at you and tell you that you need to do a better job with either your rate or your depth of compression or your release in order to improve your CPR. So again, this has been added to the guidelines not as a you will do this, but more of a if available, please utilize it, because there's some indication that we may be improving our resuscitation by utilizing these devices. So having said that, we're going to move into our first scenario, which is a ventricular fibrillation cardiac arrest scenario. We're going to be in the field with a 7-year-old who arrests.
Joey, are you okay? Joey, stop messing around. Oh God, help, he's not breathing, he's turning blue. Call 911, get an AED.
Evan, what's going on? What's wrong with Joey?
Dr. Ferris, Joey collapsed, unconscious. I only learned hands-on CPR in health class last month.
You're doing a great job with those compressions. I'm going to go get an AED and call 911. I'll be right back. Yes, this is Reed Ferris. Can you move to the other side? I'm at the Sandpoint Tennis Club at the corner of 65th Street Northeast and 15th Avenue Northeast. We have a 7-year-old who collapsed and is receiving CPR. Can we get a medic unit here, please? Okay, great. Thank you. Good work with your compressions there, Evan. I'm going to put some AED pads on. Keep going hard and fast at about a rate of about 100. I'm going to put these pads on while you continue to do your compressions. Okay, good job. Excellent. Okay, for this to analyze, you're going to have to step away.
Analyzing heart rhythm.
Great.
Do not
Now, while
ice
I'm
the
working
patient.
on this, can you go to the front entrance and get EMS here? That would be great.
Shock advised. Charging. Stay clear of patient. Deliver shock now. Press the orange button now. Shock delivered.
All right,
Pause.
I'm going to continue one-person
Begin
CPR.
CPR.
The ratio of 30 compressions to 2 breaths.
Dan Hector for EMS.
Hi, I'm Dr. Reed Ferris. I'm a pediatric ICU doctor. This is Joey. He's a 7-year-old, previously healthy kid who collapsed. We've been giving CPR, had the AED on him. It delivered a shock, and we can move to a 15-2 ratio. Here's 15.
Okay, when we're ready, let's put this backboard on and transition over to the gurney.
Okay, great. Maybe if I get done with this cycle, we can move him up with the pulse check. Here's 12, 13, 14, 15. Okay, all right, let's do this cycle. There's 14 and 15.
1, 2, 3.
I'm Jen from EMS. I'm going to put on our
I'll
pads.
resume compressions.
Okay.
Yeah, I don't feel a pulse.
10, 11, 12, 13, 14, 15.
Sneak these
Nice
in your hand.
breaths. Good chest rise. Resuming compressions. 1, 2, 3,
Next cycle, we'll roll them and put the back pads on.
9, 10, 11, 12,
Great.
13, 14, 15. 2 breaths.
Let's roll him.
1, 2,
I'll get stuff to start an IV.
6,
Great. And Jen, I don't know how much Joey weighs.
13.
I'll grab a
14,
Braslow as
15.
well.
Okay,
Good
great.
chest rise.
So our filtered rhythm on the monitor still shows, well now shows ventricular fibrillation. So we'll have to continue to work down that algorithm. Electricity, epinephrine, and then we'll consider lidocaine. I'll
10,
estimate his weight while you get IV access.
14, 15.
Thank you.
1, 2,
Looks like he's estimated at 25 kilograms.
9,
Okay, I got an IV in his left AC.
14,
Great.
15.
So, Jen, if you can draw up a dose of epinephrine, it's 0.01 milligrams per kilogram, so 0.25 milligrams for this 25 kilogram.
Okay,
Kid?
0.25 milligrams of epinephrine.
Great. And then, Hector, I'm going to charge to 50 joules. And then when we do a rhythm check, we can
14, 15. 2 breaths.
determine whether if he doesn't have a pulse, we can give him the second dose of electricity.
9, 10.
I have the dose of epinephrine ready.
13, 14,
So
15.
I'm charging. Do you have a pulse for him? I still see V-fib
I do not.
on the monitor. Okay, if everybody can stand clear, I'm going to
clear.
deliver shock.
I'm clear.
Okay, shock delivered.
Would
Would you like me to give that epinephrine?
2,
Yes,
3,
please.
4, 5, 6, 7, 9, 10.
0.25 milligrams of epinephrine is in. Hector, would you like to switch on the next?
I will transition over. 1,
After these 2 breaths, you can go ahead and switch with Hector.
5,
Hector, you're getting good depth of compression and good release
12,
at a good rate.
13, 14, 15.
I'm giving 2 breaths.
Great. So I'm still seeing ventricular fibrillation on the monitor. I'm going to charge him up
13,
to
14, 15.
100 joules, which will be 4 joules per kilogram for the second shock. I'm going to charge it, and on the next pulse check, if he doesn't have a pulse, we'll deliver that second shock.
13, 14, 15.
Hector, if you can drop another dose of epinephrine and then a dose of lidocaine, 1 milligram per kilogram, so 25 milligrams of lidocaine.
25 milligrams of lidocaine
13,
and 0.25
14,
milligrams
15.
of epi.
Okay, so it's charged. When you're ready to do a pulse check, let me know.
I have our lidocaine and
13,
epinephrine ready.
14, 15.
Want to do a
You
pulse
check a pulse for me?
We have no pulse.
No pulse. I still see VF on the monitor. If everybody can clear,
Okay,
this
I'm
is
clear.
electricity dose number 3. Go ahead and resume compressions. Great.
And I have our 25 milligrams of lidocaine ready.
Okay, great. Yeah, please dose that now.
13, 14, 15.
Yeah, it's a good rate.
25 milligrams of lidocaine in.
Okay, excellent.
Thirteen, 14, 15. Thirteen, 14, 15.
Okay. Why don't we do another pulse check here? I'll charge us up to 150 joules, just in case he is
14, 15.
still remains without a pulse. Pulse? Does he have a pulse?
There's no pulse.
No pulse. Okay. Hold on. Clear. Everybody's clear.
Clear.
Sorry.
Press charge.
Now I'm charging at 150 joules. Shock delivered. Go ahead and resume CPR.
I also have that 0.25 milligrams of
Okay.
epinephrine ready.
Excellent. 0.25 milligrams of epinephrine would be great. IV.
13, 14,
0.25
15.
milligrams of epinephrine IV in.
Good.
13, 14, 15.
Genevieve, you're getting
Let's
tired.
do another.
I'm okay right now.
Okay.
Good. I'm feeling good pulses with your compressions.
13, 14, 15.
And actually, I have a pulse when you're pausing for the breath, so why don't we do a pulse check? I've got him at a rate of 130.
I do
on
feel a
the
pulse.
monitor. You feel a pulse? Okay, great.
It doesn't look like he's breathing well on his own, so I'm going to continue rescue breaths at every 3 to 5 seconds.
Okay, good. And now he has a peripheral pulse as well.
Should we get set up for transport?
Let's set up for transport and transition to
Great.
the hospital.
And let me summarize for us here. So 7-year-old, previously healthy kid, collapsed on the tennis court. VF was the rhythm we identified on our monitor. He got 1 dose by the AED at 50 joules, a dose of 100 joules, and a dose of 150 joules from our defibrillator. Dose of epinephrine, dose of lidocaine, and has now spontaneous circulation.
Great, thank you.
1,
It's locked.
2. Are we ready to train?
Yep, I'm ready when you are.
Very good. Thank you, team. So the point of that scenario was to highlight a couple of changes with the antiarrhythmic medications on the new PALS guideline. So in 2000 and 2005, the VF or pulseless VTAC algorithm recommended amiodarone or lidocaine. Some data, some of it in adults, suggests that lidocaine is as good, if not better, than amiodarone. So the algorithm has been updated for ventricular fibrillation or pulseless VTAC refractory defibrillation. Lidocaine or amiodarone is recommended. The dosing remains the same, and you'll see it in the new updated guidelines here on the algorithm. So the rest of the algorithm remains unchanged. In the 2010 guidelines, amiodarone was kept here alone with consideration of lidocaine. But now in the 2015 guidelines, lidocaine is brought in being an equivalent choice. Again, remember this is a bolus dose of amiodarone at this stage of resuscitation. This is not an infusion of amiodarone, so it's a 5 milligram per kilogram bolus dose. In addition, with increasing data on therapeutic hypothermia after pediatric cardiac arrest, we have some updates in the recommendations there. The THAPCA trial for out-of-hospital arrest has been published, and in that patient population, the pediatric outcomes did not differ between therapeutic hypothermia and aggressive normothermia. So the updated guidelines have now made these equivalent. So if you're going to cool your patient, they can be cooled for 48 hours from 32 to 34 degrees, followed by 72 hours of slow rewarming, or 5 days of aggressive normothermia, trying to prevent fever, which we think we know is bad for outcomes. The results of the in-hospital arm of THAPCA is still pending, so we have less data to suggest particular recommendations. We're now going to move into our neurologic deterioration section, and Dr. Joan Roberts.
Hello, everyone out there around our region. I'm Joan Roberts, and I'm going to talk a little bit about a section of clinical deterioration that's not quite as well addressed in PALS, but is more frequent in a tertiary care center or any place that is taking care of more complex patients. One of the things that we've noticed here at Seattle Children's is that there was more confusion about when to call for help regarding neurologic changes. And initially we had suggested a very low bar of essentially any neurologic change. And what we found was that that was not adequate information for our staff. So our current recommendations about when to call for a code or activate an emergency response would be any patient with new onset seizure. Differently from patients with an underlying seizure disorder, a new onset seizure could represent anything from simple epilepsy to an intracranial hemorrhage to infection. So it's important in the first seizure to call for help. Another reason to activate an emergency response would be for persistent seizure activity greater than 20 minutes, or any seizure activity where cardiopulmonary compromise is present. This is in light of good evidence that patients with prolonged seizure activity can ultimately have brain injury and scarring. So we want to have all of our other therapies available to us if the seizure lasts longer than 20 minutes. Another indication for calling a code would be new onset anisocoria or significantly altered mental status in the presence of bradycardia and hypertension. And what we're thinking of here is the patient who presents with increased intracranial pressure, who is at risk for Cushing's triad and ongoing herniation. Another indication would be simple loss of consciousness. This is certainly different from sleep. But in a patient with sudden loss of consciousness, that would be an indication for a code. And finally, a sudden change in motor function or speech. And this shouldn't be a gradual progression, but more what we're worried about here is the patient with a stroke or other embolic process, in which there could be some emergent therapeutic function that's available. So having gone through these, I want to also focus on some communication tools that are endorsed not only here at Children's and throughout, but in PALS, that strong communication is really effective at delivery of emergent care. So as we go through our next few scenarios, really be watchful for what are known techniques to enable teams to communicate well. So the first is to look for readbacks and repeats. The next is the readbacks and repeats is particularly important in communication around medications or numeric. We've all heard discrepancies in decimal point errors or drug medication errors that can be eliminated by close following of readback and repeat. Similar thing to emphasize is the call and response checklist. You'll see our teams use a checklist, and what we're asking for is not simply affirmation that an item has been named, but very specific response that adds further information besides just the presence or absence of something. So look for that. Another is the use of summary statements by the team leader. This allows shared mental model for all the people at a resuscitation to know what's expected and where the team is headed. Look for a S-bar, which is a communication technique that fosters communication in clarifying what the problem is. You'll see that in our next scenario. Our other error prevention tools that I'm listing here are ARC, which is how to communicate a question in an organized fashion, and STAR, and that's really about not being distracted and focusing on what you're doing and avoiding interruptions. I want to highlight two tools that are in place here at Seattle Children's, really for our other institutions to think about employing. I'm happy to share any of this information. The first here is a tool that informs staff what to do while they're waiting for the code team. Since the campus here now is 22 acres, and our code team is greater than a quarter mile from some of our ambulatory sites, this gives staff that are waiting for the code team's arrival some basic things that they can work on while they're waiting for the team to arrive. It says perform as feasible. It just depends on where you are and how many people you have, which parts of this you'll be able to accomplish. And finally, I'd like to share with you a transport checklist that's been in use on our code carts as well as throughout the institution to try to prompt teams to really consider what they'll need in the vulnerable situation of moving the patient around the hospital. And in particular, notice as you watch this used that a challenge and response checklist has very specific things it's trying to accomplish broader than a yes-no reply. And I know that there's a lot of folks here from the operating room teams who are very familiar with using checklists and having specific answers that they're looking for, not just, yep, we said the words on the call part, but what we answered is important. So at this point, I'm going to switch over and present to you a patient. This patient is in the surgical floor here. You're going to see our teams caring for a 16-month-old boy who is admitted. This patient has a history of developmental delay, seizure disorder, hydrocephalus with a VP shunt, and has been admitted with a fever, vomiting, and intermittent altered mental status. The patient's been started on IV antibiotics and had their shunt initially evaluated in the emergency room with a head CT and a shunt series. So our bedside nurse is taking care of this patient who's been intermittently agitated and has had about 30 minutes of increased blood pressure and was then treated with a bolus of morphine.
Isaac, are you okay? Can I get some help in here? He's not responding.
Hi, I'm the charge nurse. What's going on?
Hi, Jen. He became unresponsive, and it looks like his left pupil's dilated. I'm going to raise the head of his bed. I'm concerned he might be herniating.
All right, let's sit him up, and he's totally non-responsive for you?
Yes.
Okay, I'm going to call a code blue and get some more help.
I'm going to start back max ventilation here.
Hi, this is Jen.
26 to 30 breaths per minute.
I'm going to call a
I'm going
code
to try and
blue
hyperventilate
on
him.
River
Okay.
5, room 204, on River 5, 204. There's some things we can do before the code team arrives. Let's review those. So we've initiated BLS, your bagging. I've called code blue on our stat line. We have all the lights on. We have him on a monitor in a pulse ox. Is he on bolus feeds or continuous feeds?
He is, and I'll stop those.
Perfect. Let's move the bed to the middle of the room and get everything off the bed that we do not need. And then can we have the code cart brought in? Heather, can you bring the code cart to the room, please?
Got the code cart.
And can we get defibrillator pads on him if you have them?
Hi, I'm Joan Roberts. I'm one of the ICU attendings, and I'll be the team leader.
I'm Sylvia. I'm one of the PICU fellows. I'll be the survey doc.
I'm Elaine. I'm one of the nurses, and I'll be drawing up medications.
Can you give me an update on what's going on here?
Sure. I'm Hyen. I'm his primary nurse. He became acutely unresponsive. He has a VP shunt. He came in with a fever, vomiting, and he was irritable. His left pupil is dilated, his heart rate is low, and his blood pressure is high, and his respirations are slow and irregular, and Hector is bagging him right now. We're concerned he might be herniating, so I elevated the head of the bed.
Thanks. It sounds like for this young man, we're facing potential
high intracranial pressure emergency. So at this point, I'd like you to call neurosurgery and let them know we've had this deterioration, as well as the radiology to get a CT in the works. Can we continue to treat medically with hyperventilation? And then can we draw up a code dose of mannitol as well as 3%?
Yes, can I confirm that for his weight of 12 kilos, we're going to use mannitol 20%, and the dose for him would be 12 grams.
That's correct.
I need to
And
have
this is
CT ready
Nebia
for a
Heaven,
patient in
570-1221.
That is correct.
Great.
Joan, an update for you. This patient will move to painful stimuli, does not overbreathe with bagging, and
Dr.
the left
Smith.
pupil is
There's a charge
now
nurse on
sluggishly
RC5.
reactive and
We
no
have a
longer
patient with
fixed.
some neurological
Great.
deterioration.
I think we
Joan
want
Roberts,
to
the
continue
PQ
to
attending,
mask
has asked that I
ventilate
call
at
you.
a fast rate to try to get
Perfect.
CO2
You'll be
down
here
in
in
the
15 minutes.
25 to
Thank
30
you.
range. I think you might have to transition over to the airway roll at this point and secure a airway before we travel to CT.
Are you okay with etomidate and succinylcholine for intubation?
That's perfect.
Okay, we'll get that
CT
going.
is ready and aware, and neurosurgery said they'd be here in 15 minutes.
Terrific. So it looks like we could secure the head in a good position with some towels, and maybe call the parents and let them know where we're going.
Do you need help repositioning him?
I do need help repositioning.
Here's mannitol, 12 grams. It's
intubation.
already been filtered.
All right, let's go ahead and reposition.
Can I
Control
confirm
airway?
that we're going to give both mannitol 20% and hypertonic saline?
That's correct. And did you hear the etomidate and succinylcholine would be the medications for the airway?
Okay, and for hypertonic saline, 3%, 12 milliequivalents?
Yes.
And then if you can give the etomidate and succinylcholine next, that would be great.
The mannitol 12 grams was given.
Okay, and etomidate, for 12 kilos, we're going to give 3.6 milligrams, 2 milligrams, sorry, 0.3 milligrams per kilo.
That's correct.
And succinylcholine, we'll give 12 milligrams, 1 milligram per kilo.
Maybe we can get our transport equipment ready in the meantime.
Perfect. So suction.
So we'll need to place
Your
the
etomidate,
portable suction on the
1.8
bed
or
and check
3.6
that that's
milligrams,
functional.
and
Oxygen.
succinylcholine, 12 milligrams.
RT, at your convenience, can you check to see that our cylinder is full?
Etomidate 3.6 milligrams given.
Great.
And sucks.
Airway,
Is
which
given.
we're establishing now.
Mm-hmm.
Medications, what would you like available on transport?
Here's your hypertonic
As soon as you're
saline.
ready, Elaine, we'd like to bring a dose of epinephrine, some normal saline, 10 cc per kilo bolus, and an additional dose of mannitol with us in transport.
All right, and can I confirm epinephrine? Do you want the concentration 0.1 milligram per ml?
Yes, the IV code dose.
All right, you can continue bagging.
Joan, you wanted
Yes,
the
I'll have it
3%
ready.
given, correct?
Yes, please.
So the team, can we confirm who's coming on transport?
Saline given.
We'll need respiratory therapy.
I'll come as charge nurse.
Our bedside nurse and a
I'll come as
medication
medication
nurse
nurse,
as well.
yes.
Okay, the route, I'll call security to make sure they are holding an elevator for us.
Terrific. We'll let CT know we're on the way.
And then we have our recorder, which can accompany us on the way.
Any other
Let's flip them back.
concerns the team would have prior to transport?
I have no concerns.
Great, thanks for keeping the head of the bed up. And once our airway is secured and we have everything, we can head off to CT.
Our airway is now secure and ready for
You can take over bagging.
Heather, do you have the transport monitor that we can transition to?
Yes. And we have suction.
Thank you for checking chest rise.
We'll want to
You've
keep
got good
our
breath sounds
CO2
bilaterally.
25 to 30 en route.
Is everybody ready to go?
Yes.
We're ready.
Yes, I'm ready. I'll have the elevator ready.
We're now going to move on to our final scenario, which is going to highlight some of the guidelines around individuals with septic shock. We are going to be in the emergency department this time with a 4-month-old brought in with concern for fever, lethargy, and poor oral intake.
Hello, hi. My name's Elaine. This is Bessie, and you're Bessie's mom?
I am.
Great. I understand Bessie's 4 months old, and she's had a fever now for 24 hours and not been eating well or drinking well.
Yeah.
Not true. Okay. Has she been this sleepy? And
Yeah,
working
she's been really sleepy.
harder to breathe?
No, just has been hard to wake up.
Okay.
Hi, I'm Dr. Loudon. I'm one of the ED fellows.
Hi.
So I understand that Bessie has been having fever for the last 24 hours, hasn't been feeding as well, and has been very sleepy. Is that correct?
Yeah.
I just want to ask a few more questions just so we have a little bit of history on her.
Dr. Loudon, her SATs are only 92 to 94. Can I go ahead and put her on some oxygen?
Yes, please. If you could put her on 5 liters, just
Sure.
a simple face mask, that would be
Thank
great. So she's not currently on any medications, is that correct?
No medication.
Okay, and you haven't given her anything recently?
No.
Okay, does she have any other medical problems?
She's never been sick.
Okay, any allergies to any medications?
Not that I know of, no.
Okay, and anything else happened recently that you want to tell me about? Any new rashes, anything else?
No, none that I've noticed.
Okay.
And it doesn't look like she has any rashes.
I tried feeding her a few hours ago, and she just really wouldn't take to it. Stopped after about a minute, and I haven't been able to wake her up really to eat since.
Okay, so that was about 4 hours ago that she had her any last intake?
4 to 6 hours ago, I'm not sure when.
So Elaine, she's still pretty tachycardic and she's still not satting very well on the 5 liters on the simple face mask. So I think we should probably activate our sepsis pathway.
Great. She's not very arousable. I'll call and get some more assistance in here.
Okay.
Okay, our sepsis code is now activated.
Elaine, I'm your charge nurse.
Hi, I'm Dr. Reed. I'm the attending in the emergency department.
Hi, Dr. Reed. So this is Bessie Rose. She's our 4-month-old, otherwise healthy female on no medications, no allergies. Who's presenting with 24 hours of fever, lethargy, who's tachycardic, and is now on 5 liter simple face mask and is still somewhat hypoxic.
Okay. It sounds like as a team we should do a full assessment and then come up with a plan together. So let's get into code roll. I'll be the team leader.
Okay, I'll be the survey doc.
I'm Jen from RT.
I'll be the communication charge nurse. Hector.
I'm Hyann, I'm the resource nurse.
I'm Elaine. I'm her nurse, and I'll be the med admin nurse.
So her airway's intact. She has increased work of breathing with suprasternal and subcostal contractions. Her breath sounds are coarse. She's tachycardic to the 180s, 190s. She has regular rhythm, no gallops. Her pulses are very thready. Her cap refill is about 5 seconds. Her skin is very mottled. She has no other rashes, no other lesions on her exam.
So Bessie sounds like a 4-month-old who's previously been healthy, who I'm now concerned is in decompensated septic shock. Okay. I think our first priority is to get IV access, and if we can't get IV access, to then place an IO. And I'd like to give fluid, so normal saline, IV code doses.
Normal saline, heavy code doses, and our EasyIO is ready.
I do not see any place for access. She's really shut down. Do you want me to prepare her leg for you to do an ECIO?
Yes, please. Dr. Reed, I'll place the IO in the right tibia.
And then Hector, if you can get that normal saline bolus ready, I'm going to let Mrs. Rose know what we're doing.
Our normal saline ready. Bolus is ready.
We're going to go ahead and use some IV.
I'm placing the Easy IO in her right tibia, just medial to her tibial tuberosity.
Great.
Our checklist here for septic shock.
Thank you for giving me the septic shock algorithm.
Easy IO is in, the stylet is out. Elaine, if you could please draw 5 mLs of blood for culture and for labs.
Supplies
Looks like their
And a
SATs didn't
syringe.
really improve with this. You want to switch to a non-rebreather?
Yes, please.
I'm getting blood return.
Great, so let's make sure we send
Use a
labs.
flush syringe.
So our lab should include electrolytes, a CBC, blood cultures, and EPOC labs, so a VBG lactate and an ionized calcium.
Okay. We'll start our point of care testing and send those to the lab.
Great, thank you.
Your ECIO flushes, stop, behind, and beside.
And I have your normal saline bolus ready.
Great, and that was 20 mLs per kilo, and she weighs 6 kilos, is that correct?
That is correct.
Okay, so we're going with 120 ml.
Okay, I'll go ahead and push the cap.
And then Taylor, once this first bolus is in, let's make sure we listen to her heart again so that we don't
60
hear any
cc's is
gallops,
ready.
which would make us concerned she's in heart failure, that we don't hear any crackles in her lungs or feel that liver edge going down. All right, we should also get a second bolus ready. So another normal saline, 20 mLs per kilo. And we should make sure we order antibiotics for her as well. So some nice broad spectrum antibiotics. Our goal is to get those in within the first hour.
Okay, I'll work with our pharmacist.
Okay.
Confirm the bolus you want is 120 mL.
That is correct.
And the IO is flushing well. It remains soft. The first 120 mL is in.
Dr. Reed, I will reassess. The breath sounds are still clear. No gallops or rubs. Liver is still under the rib cage. Her pulses are still thready, but her cap refill is slightly better, about 3 to 4 seconds.
All right, sounds like she's tolerating the fluid well and improving just a little bit. So I think she's going to need that second bolus. I did order the ceftriaxone.
And we just received this and
Great.
confirmed it with our pharmacist.
Okay.
Do you want me to go ahead and start the second bolus now?
Please start the second bolus and give the ceftriaxone as soon as you can.
120 mL starting.
Dr. Reed, I also have the lab results.
Great.
Her CBG came back with metabolic acidosis with a pH of 7.18, PCO2 of 24, PO2 of 20, base deficit of -18, a lactate of 5, hemoglobin is 11, glucose is 185.
Those labs are consistent for me with septic shock. Any other thoughts on those labs?
Would you like me to get high flow set up or nearby?
That sounds like a good plan. I think she's going to need to go to the intensive care unit. She's probably still going to need more fluids, and she might need more support for her blood pressures if they don't continue to improve.
The second bolus, 120 mL is in.
And I'm
Dr. Reed,
starting.
I'll reassess.
Okay.
And I'm starting her ceftriaxone now.
Thank you.
Lungs remain clear. Her tachycardia has slightly improved, but she's still tachycardic to the 180s. No rubs or gallops. Liver is still not palpable. Still has 30 pulses, but her cap refill continues to improve. It's about 2 to 3 seconds now.
Okay. I think she's still tolerating the fluids well. So let's get the third bolus ready, and I'll call the ICU attending.
Did you want to call and pre-order norepinephrine in case we need?
That's a great idea. I'll order that as well. Hello, ICU. Can you come on down to the ED?
Hi, Dr. Reed. I'm Sylvia Hartman from the ICU. How can I help you?
Hi, Dr. Hartman. This is Bessie. Bessie's 4 months old. She's been previously healthy, and over the past days, she's developed lethargy, fevers, and we think she's in decompensated septic shock. At this point in time, we've given her 2 boluses of normal saline. I think we're starting the third.
The third is going in.
In addition, we've given her ceftriaxone, some broad-spectrum antibiotics, and our goal was to get all that in the first hour. I think she's going to need more support, though, so I think an ICU bed is probably where she's going to need to go. You might need to intubate her later. She might need norepinephrine for more blood pressure support.
I agree that she's definitely going to need an ICU bed. I will facilitate that. From what you tell me, it sounds like she has cold shock, so might I recommend some epinephrine instead of norepinephrine?
Thank you. All right, we'll take a look. I'll order that. Okay.
The last bolus is in.
Thank you.
For a total of 60 per kilo.
Okay. So let's talk about how it went. What do you guys think?
I think we recognized that the child was sick promptly, and Dr. Loudon made it very clear that this child needed to be on the septic shock pathway.
It was really helpful to have summary statements when we entered from both the team members that were present in the room. That was helpful to both have a shared mental model and our next steps so that each of us could have a designated role.
I appreciated that the room was quiet so I could hear sign out about this patient.
The closed loop communication was good, and I knew what was going on the whole time.
All the supplies are readily available for the EZIO.
Anything you guys think we could do better next time?
There were some instances where I feel like we may have been talking on the side, and I don't know if that was distracting to others. But again, just being able to hear clearly from our team lead is helpful.
Thank you, guys.
Excellent. Thank you for all the teams working through all the different scenarios. I will briefly summarize some of the, I wouldn't even call them changes in the septic shock guidelines for this iteration. There has been some new data published from outpatient or from hospital settings in Africa that demonstrated in kids with severe febrile illness, their tolerance of fluid resuscitation was poor, and actually aggressive fluid resuscitation resulted in worse mortality in that population. So the PALS committee has couched the recommendation for fluid resuscitation in the need and ongoing focus for frequent assessment of our patients, both before and after fluid resuscitation, and to be judicious in settings that do not have critical care resources available. So being mindful of your setting, where you're treating patients, and what their disease processes are in your local setting is important to know how aggressive on fluid resuscitation in the case of septic shock or severe febrile illness. They did also look at crystalloid and colloid for initial choice for fluid resuscitation and determine that both can be effective. There's no recommendation for one over the other at this point in time. But again, patient evaluation before and after fluid resuscitation can't be underemphasized. I bring these slides up mostly to just show you the current PALS guidelines for septic shock. Again, these have not changed, so there remains a focus on establishing and evaluating your primary survey, supporting airway breathing and circulation, getting rapid IV broad spectrum antibiotics, and rapid fluid boluses to achieve a return of normalization of perfusion and ideally vital signs, all within the first hour. But again, continuing to assess these patients and ensure that they are not having signs and symptoms of fluid overload or intolerance to fluid therapy. Again, this is the initial stabilization phase, and then once we get out of the initial stabilization phase, all of this are things that are happening in the ICU, establishing central access, utilization of vasoactive and inotropic support, and assessing mixed venous saturation, et cetera. Again, these are not new. These are the same guidelines as from 2010. So in summary, for our 2015 update, a continued focus on high quality CPR with a rate standardization, use of CPR feedback devices, and recommending against the routine use of atropine pre-intubation. Amiodarone or lidocaine are felt to now be equivalent for shock for shock refractory ventricular fibrillation or pulseless VTAC. Targeted temperature therapy recommendations for plus minus on out-of-hospital arrest. We're still waiting for the in-hospital data. And that fever should be aggressively treated. We do know that fever is bad for your neurologic outcome. And for sepsis, aggressiveness of initial fluid resuscitation should take into consideration the clinical setting, resources available, and ongoing assessment before and after fluid resuscitation remains paramount in septic shock. With that summary, I will turn it over for questions. If anyone in our local audience or anyone remotely has questions, we're happy to answer those at this time.
I wondered about the mention of some pathways, and if people in other areas of states have access to looking at pathways that are not Heart Association, but rather from Seattle Children's evidence work.
Yeah, so the Heart Association has not recommended establishment of pathways, but obviously the Heart Association is interested in getting guideline-supported care to our patients regardless of where they are. Seattle Children's does have a focus on pathways of various types that are clinically relevant for the particular patient, and all of those are available on our website that can be accessed externally, seattlechildrens.org. If you look under clinical standard work and clinical pathways, you can find those. In that includes work done for septic shock in particular. Our pathway spans the settings, but we have the most robust data around detecting septic shock in our emergency department patients. So those patients are screened and then placed on the pathway that was mentioned in this scenario. Yeah. Thank you. Other questions? Yeah.
When you're using devices like the Zoll with the see-through CPR, should you be doing a rhythm or a pulse check every 2 minutes still, even though the Zoll is, it gives you the rhythm?
Right. Good. Yeah, so what she's hinting at is that the Zoll has that ability to kind of filter, quote unquote, filter the artifact from CPR so that you can, quote unquote, see the underlying rhythm with the CPR artifact removed. That helps you know what the patient's rhythm is with ongoing CPR, but if you have an organized rhythm on that tracing, you won't know if the patient has spontaneous circulation unless you hold compressions to check a pulse. So if you have a rhythm on the monitor of 80 at a rate of 60 or 80 or what have you, unless you hold compressions, you won't know whether that person has spontaneous circulation or not. So to determine whether the patient still needs CPR, you will potentially need to hold compressions to feel a pulse to understand whether they have PEA, which would be electrical activity without a pulse, versus spontaneous circulation. In the setting of our scenario, our underlying rhythm was ventricular fibrillation, which by definition is not a perfusing rhythm. So you know if the patient is in VFib, they do not have a pulse by definition, so that can help you speed up and make your process more efficient on treatment, et cetera. Yeah, good question. Thank you. Yeah.
So I just wanted to close up and say that to our audience out there that if you would like to download the PDFs of this presentation, they're available on our .org site, Outreach Education, Outreach Conferences, under Nursing Grand Rounds, the presentation's available there. And if you would like to receive a septic shock pathway, we're happy to send that out to you. Just email outreacheducation@seattlechildrens.org. And just thank you to everyone who participated today.